associate for the center. We host a pretty wide variety of social entrepreneurs every week, and unless noted somewhere else, it's at the same time and place. There is a sign-in sheet going around. Actually, we could circulate that. And if you sign in there, I'll send you a weekly newsletter with updates and events like this one. So next week, we have Kristen Morrissey, who's joining us from Google Fiber. Today, though, we're very excited to have with us Conor Shapiro, Middlebury class of 2003. Conor is the president and CEO of the St. Boniface Haiti Foundation, which specializes in healthcare, education, and community development in rural Haiti. Conor actually went on his first trip to Haiti in 2002 as a Middlebury student, and upon graduation volunteered with the foundation as an English teacher. He's held various roles at the foundation since then, and received his MPH from Boston University, and is now, since 2011, the president and CEO of the foundation. So I don't want to take up too much time. I know there's a lot of great material here, but I just want to thank you again for coming, and please join me in welcoming Conor.
Thanks, Eddie. I feel totally old here, coming back and being in this building and being totally lost as to where I am. This used to be the library when I was here in 2003. I remember writing my thesis upstairs. I think there's an upstairs here still, with wacky shag carpeting, and I feel really old being back here in the building and being really lost. But thank you for having me back. So when I graduated in 2003 from here, and my last couple of years here were really formative in terms of going back to Haiti. I owe a huge debt of gratitude to this place, and actually a lecture similar to this one with a way more prestigious speaker than me was a real catalyst for me going back to Haiti when Paul Farmer spoke here in 2002. And I was just joking at lunch, when I spoke here, there were actually less people for Paul than there are right now who came to see him speak. It was just not, global health was not the same kind of draw that it is now. And I'm totally blown away by your commitment, Middlebury's commitment to global health, international development, to all these different fields that back then just weren't as, didn't generate the kind of interest they do now. So I'm really grateful for this generation of students and the work that you guys are doing in GlobeMed and the Center for Social Entrepreneurship, Midcore, all these things that didn't exist in 2003. It's amazing to see them in action now and see you guys in action. So I started as an English teacher in Fond-et-Blanc, and I thought I was going to stay for a year. And Fond-et-Blanc's about 4 hours outside of Port-au-Prince. Thought I was going to stay for a year, see how it went, and then return, and I didn't really know what my plans were. I was, a typical liberal arts college student, not knowing where I was going, and just decided that I would be teaching English in the local school through St. Boniface. And over time, I got more and more involved in global health programming, especially around HIV and AIDS. When I was there in 2003, when I first started, the AIDS epidemic was at its height. We didn't have the antiretroviral medications that we have now being dispersed in developing countries. They existed, but no one was actually thinking that they were a quote-unquote cost-effective way of taking care of AIDS, that we should be doing more prevention, not treatment of HIV and AIDS at that time. And so where I first started to really get involved in global health programming was we started an HIV/AIDS care and treatment program in 2004, really modeled on the Partners in Health model in the Central Plateau that was being rolled out, and it was an amazing experience. When I first started in 2003, it was a total death sentence. AIDS was a total death sentence. We had so many people in this rural community who were dying in the prime of their lives. We had mothers with lots of children who were dying really unnecessarily. We had the drugs. They existed. They existed here in the United States. They existed in Europe. Everyone was using them. But in a place like Haiti, where the burden of disease was that much worse, we couldn't get the drugs. And the global health community was really divided. But most of the time, the majority was saying, well, it's just not cost effective. The treatment course is too expensive. And so the treatment course at that point was, I'm trying to remember the numbers, but I think it was like $25,000 US dollars a year to keep somebody on antiretroviral drugs. And what other people, activists within the global health community said, well, why is it so expensive? Why is it $25,000 a year for the drugs? I mean, now in 2014, it's $250 a year for those same drugs. And by the work of some of those same activists in bringing down the cost and making it changing the debate from, oh, we should just do prevention, to, boy, these lives matter of the people who have AIDS right now, they were able to really bring down the burden of disease and really extend the lives of so many people and make AIDS into a chronic illness. So that huge shift has happened just in those, it really happened in 5 years, between 2003 and 2008, and now it continues. But to see that change for me really was, once I got involved in that program, I wanted to work in global health. That's what I wanted to be part of. And so now our organization has a variety of different health, education, and community development programs. We have a hospital that sees about 50,000 patients a year. We have community health programs and mobile clinics that are going out every day on motorcycles in rural communities all around the hospital. We have a new maternal health center that's being built. We have an outlying clinic that was destroyed during the earthquake in 2010. It's being rebuilt and will be online in the next few months. We have education programs, scholarship programs. We have about 800 kids on scholarship in our area. But one of the things that we're really most excited about is a university scholarship program, where we have kids from this rural area who would usually not be able to go on to university. We're able to go on to university and then come back to the community where they're from, these rural communities, doctors, dentists, lab techs, agronomists, and really have an impact and return home to have a major impact. So all these programs that we're running are very interconnected. And then we have community development programs too, which are on a smaller scale but are growing for us. Mostly around water and sanitation programs, latrines, drilling wells, as well as teaching best hygiene practices around prevention of disease. So lots of different community development programs, but also around economic development projects. On a small scale for now, we have some chicken breeding project, as well as goats and livestock, and fishing programs as well. Those projects, community development projects, have really risen out of the listening to local voices. So the local community was saying to us, okay, the health programming is important, we want it to continue and grow. The education piece is good, but we need to create jobs and stability here as well. And so we've worked very much with local peasant cooperatives around the projects they want to do. And so a lot of those projects have risen out of their ideas of what could be done. The goat project, for example, is one where we've taken the local Haitian goat and crossed it with we call the super goat. And the super goat is a Boer goat from South Africa, much bigger, and they've been able to create a much better meat output from these larger goats. And that project was totally designed by the peasant cooperative, but they needed the money for the larger goats. And so we were able to bring in those larger goats from the Dominican, and it's gone really well. Now Haiti, now funded where we work, is now known as the goat capital of the South. So people are coming from all over the South and getting goats from the local market. It's been a great success, but really has been designed by the local community. We just had to infuse some of the capital. So I thought I'd talk a little bit, we'll try and make it maybe 40 minutes of talk and then really get to question and answer, because I want to open up and hear your thoughts and questions about our work. But I thought I'd talk a little bit about some of the lessons learned over the 10 years that I've been working in Haiti. So I've lived, going in circles here, but I lived in Haiti for 7 years after graduation in 2003. And then about 9 months after the earthquake, started working out of St. Boniface's office in Boston, and now I go down about 1 week a month. Or I thought I was going to change a slide. Do I press this button? This arrow? About that. There we go. So, we used to have, there used to be a teacher here, Timmy Meyer from the geography department. Now, is she still teaching as well? So I should have emailed Timmy before I came up here, so I'm embarrassed. But Timmy taught a class called Geography Development. She still teach that class? And she used to always open it up by saying, what is development? Or she used to say it all. She used to ask us all the time, "What does development look like? What is the definition of development? Who's development? Where is it coming from?" And those questions used to drive me nuts when I was working in rural Haiti, constantly thinking about the work we were doing and whether we were actually doing quote-unquote development. And so in a rural community like Fondé-Blanc, but also in Haiti, where the key word that everyone's talking about is sustainability, right? Haiti is extremely poor. It's the poorest country in the Western Hemisphere, terrible health outcomes. It looks a lot like a lot of sub-Saharan Africa's health indicators, even though it's an hour and a half from Miami. It's just a very difficult situation and real extreme poverty. Yes, everybody knows that, but what does sustainability look like in a place like Haiti, in a town like Fondé-Blanc, a rural town like Fondé-Blanc, where we're working, about 4 hours outside of Port-au-Prince? So I think the number one thing is the priorities have to be driven by the local population. There's a saying in the disability world, "Nothing about us without us." And I think it's a very important thing for us to realize. There's all kinds of development experts. There's all these different people who have all these different ideas of what can be implemented. We have groups that come down to Fondé-Blanc all the time. Everybody's got a solution for Haiti. Everybody who comes from the outside comes in and says, "Oh, haven't they thought of this? Haven't they thought of why? Haven't they thought of this solution?" Well, yes, everyone's thought of it, but it hasn't worked. And so the key really is that the local population, that the people who are farmers in the community, the people who are local church leaders, people who are the women who are traditional birth attendants, they all have to have a seat at the table in terms of deciding what the priorities are for different projects. The other piece is that skills are transferred. It's great to come in and do service delivery. So it's nice to be able to come in and say, see patients or do other work at our hospital, but there needs to be a transfer of skills from professionals here to professionals in Haiti. We have an OBGYN at the hospital. We need OBGYNs here to be able to come down and do that kind of do different kinds of training for ROB, so that the work that person is doing continues despite the groups coming and going. So constant skill transfer is very important. Maybe an ag school here in the U.S. coming down and working with our agronomists and talking about different projects they have and having collaboration around projects. So I think service delivery is nice, and being able to say provide services and come and volunteer and, see patients in an eye clinic. But really the key is that skills are transferred to Haitian professionals. That's what I think sustainability looks like with these projects. The other is that the public sector is supported. So Haiti has this reputation, I think some of you have heard of it, Haiti's been in the news so much, the Republic of NGOs. That the state is very weak, and there's a ton of nonprofits working in Haiti. And that's very true. I mean, we have almost anyone you talk to here in the U.S., when you talk about Haiti, they say, "Oh, do you know so-and-so? They work on this project." There's a zillion projects going on in the country with very little coordination. And so what we believe at St. Boniface is, if we're going to do this work, and we really believe in the local population, we really believe in democratic voices, that the local population can vote and create a public sector, then we really have to work with that public sector. It may be weak, it may be disorganized, but there are abilities that we have to build up that sector. You'll see later, I'll talk a little bit about our spinal cord injury program. We work very closely with the Ministry of Handicapped Persons in Haiti around that project. And so there's advocacy work that they do. They integrate our patients in the advocacy work they do around the country, around integrating those with disabilities. But it's crucial that public sector is supported. The fourth is, for us, that's key for our mission, is that the programs reach the most vulnerable. A lot of the times there's different development projects happening, and I think sometimes they can bring up whole communities, but in Haiti, just like anywhere, there are vulnerable people and then there are the most vulnerable. And trying to find projects, especially in health, that reach the most vulnerable is critical. So a TB program. You can do a TB program where you have all the patients coming to the hospital and you are providing tuberculosis medications for free. But one of the difficulties for the most vulnerable is to actually get to the hospital from where they are. They have to pay for a motorcycle ride, or they have to come 6-hour walk, because they're extremely vulnerable based on where they live and how remote they are. And so we've set up programs where we have motorcycles going out with meds to the most vulnerable communities and really trying to get out to where the most vulnerable are. So designing programs that reach the most vulnerable for us is a very important part of our programming. And then the other two pieces, some of these things may seem cliche, but I think they're really important to underline. One is that the interventions that we're doing in a place like Haiti or any other developing country, that we are measuring what we're doing, that we're analyzing that, we're taking time to analyze it, and then we are refining and sometimes changing course. I think a lot of the time there's a lot of patting on the back of development groups saying, oh, it's great, we were able to do this project, it was fantastic. Well, a lot of the times, we mess up all the time at St. Boniface. We have all kinds of interventions that we've done that have not worked. But the key for that is that we acknowledge they didn't work and we change course. An example would be we have a fish farming program. And I think everyone's heard of these different income generating projects. There's fish farms, there's artisanas, there's coffee plantations, or coffee cooperatives. There are all these different projects around income generation. And what we totally focused on, how are we going to, for our fish pond project, we focused totally on how are we going to produce the fish. How are we going to dig the ponds? But we never really talked about how are we going to bring these fish to market. Who are these fish going to? Who is controlling the fish project? Who is making sure that the fish get to the most vulnerable? Is this really having a nutritional outcome? Are we doing this because it's an economic development project? Are we doing this because the fish are good nutritionally for people? If they're good nutritionally for people, how are we going to make sure the people who need them the most are getting them? If it's going to be out in the open market in the community. If we say that it's a cooperative that's running it, well, what does that really mean? Is it 6 people who are working on it, who all get to get the same amount of money out of it? These may be all questions that you guys have answered, but we definitely didn't when we started the fish pond project. And so when we realized that this had become a huge problem in terms of the management of it, we had lots of more community meetings, lots more discussions, and then tried to change course, acknowledge the failure of the project, didn't just continue to produce fish and not know where they went, but discuss different ways of improving. And then so that's the last point too, is that mistakes are acknowledged and our attempts are made to improve. I think it's very difficult in a group like, say, St. Boniface, where we are very reliant on donor dollars. So we're reliant on people from the outside of funding giving us money to do work. And to do that, we are constantly telling everybody all the great work that we do. And that, there is good work going on. There's no doubt we believe in what we're doing. But it can be harder with donors to say, look, we really messed up here on the fish ponds. Because, then people might say, oh, because all the other groups are telling them how great everything is all the time, even though everyone knows that nothing can be perfect. And so it's really important, I think, to develop relationships with donor organizations, to be able to say, hey, we've made some mistakes, and now we're ready, and we know how to fix them, but we're being honest with our donor organizations to say, hey, this didn't work, this worked, and then figure out ways to make it better. So I think those are some key parts of sustainability that we've learned, and I've learned over the last 10 years. I wanted to give you an idea of the area where we're working. This picture is actually right after the earthquake in an article in the New York Times about Fontainebleau, where they talked about a lot of people coming from the earthquake, after the earthquake, and coming back to Fontainebleau because their homes were destroyed in Port-au-Prince, and they came back to the rural areas where they came from. And there's a woman who's planting corn in the middle of her field. And so she's come from Port-au-Prince. They had been living in Port-au-Prince, their home collapsed, and now they were out in this rural area, 4 hours outside of Port-au-Prince, back in the middle of Fontainebleau, trying to do subsistence farming. And this is really indicative of the challenges we're up against in Haiti. Massive deforestation and loss of a lot of topsoil, huge environmental nightmare. And she's trying to plant crops, the only source of income, the only source of nutritional intake. So trying to plant corn in the rocks. This is a bird's eye view of the area that we serve. It goes beyond that geographically, but our hospital here is in the foreground. And this is a good idea of what our area, our catchment area looks like for all the different projects we're talking about. This is a mobile clinic. This is one of our docs in the middle here. He's actually from Fontainebleau and was part of that university scholarship program that I was talking about before. There was no last year of high school, so the foundation has worked on making sure that was a key community priority. They wanted everyone to be able to graduate from high school who was able to. So we were able to fund the last year of high school at the local school. He went on, finished the last year of high school, went to university, now he's back, and he's running mobile clinics. And actually the nurse here too is Haitian and from Haiti, from Nakai. But they're out in this very vulnerable area doing mobile clinics and making sure that the most vulnerable are getting medical care. But it makes such a difference to have someone from the local community, not even just from Port-au-Prince or Haitian, but he's from the local community, understands it, and really you can see that in terms of the quality of care, having local people doing this work. So this is after the earthquake. Everyone, I think, has heard about the earthquake. There's a stat that says over 50% of American families gave to Haiti after the earthquake. So huge outpouring of support after the earthquake. And this is a picture of Fabienne, one of our patients who's now back home, living back at home in the foreground here, is being carried by Tisson, who's from our local community. And he and Nene over here on the left, they came to help carry patients who had been hurt in the earthquake, who had, in her case, she had spinal cord injury, and were flown out to the USNS Comfort, which is a Navy ship out in the bay in Port-au-Prince. And so we were landing helicopters in this mango field down the street from our rural hospital, and this was the beginnings of starting our International Center for Spinal Cord Injury, which is now flourishing. But I show this picture a lot for a couple of reasons. One is, we had no idea what we were doing around spinal cord injury, and I think we were totally nuts for taking on the project at first. And I think if anybody looked back, they'd say we were crazy, which is fair. But I think what we realized was there were going to be no other services for those with spinal cord injury, or that's what it looked like at the time. And so our Haitian staff said, and the local community said, we really need to take care of these people because they've been injured horribly. They're going to end up back on the streets of Port-au-Prince. We have to do this. And so again, it was listening to those local voices. And what happened, the local community, these guys come from real poverty, both Nene and Tisson. They got very involved in setting up the spinal cord injury program. They didn't have the medical skills, they didn't have the clinical skills to do the project. They weren't physical therapists. But by really embracing these people who had been through so much, it was a key part of making this project a success. Plus, it was really cool for everybody to be around helicopters, I think. I think that's part of it. So this is now our National Center for Spinal Cord Injury in Fontainebleau. In the background, this is Mamai. In the background, there's housing for the patient. So we have a 16-bed inpatient facility we've built in Fontainebleau. And in the background is not the inpatient facility, that's actually the family quarters for the patients. So patients' family members come out and spend 6 months, 9 months, however long it takes to do the rehab and then reintegrate patients back into the home. This picture I love because he's from the local community, and he is now doing wheelchair repair. And so before, no job, didn't have any income source, and now has been integrated into our team, has been taught how to do wheelchair repair, and now is one of the key wheelchair repairmen and also a patient advocate for a National Center for Spinal Cord Injury. And so having that skill transfer, job creation, really neat story. And this is Kenny on the left, DJ Kenny to people in town. He's actually a local radio DJ. And Maxine on the right. And Kenny and Maxine were both part of that original cohort that came in off the helicopters, and they're now part of our staff. So they live in a house off campus. They had nowhere to go back to in Port-au-Prince. They wanted to stay, the community wanted them to stay, and so now they live 4 hours outside of Port-au-Prince, and are part of, are key parts of our team, our spinal cord injury team. And we call them peer educators. So when people come in, new spinal cord injury, gunshot, falling out of mango trees, other car accidents, motorcycle accidents, these guys will make sure that they understand the ropes at the center. You know, understand the rules, understand their injuries better, understand their futures, and I think are a real great source of hope for our patients. One of the key parts too is with our spinal cord injury program, similar to our foundation where we look at health, education, community development, because they're also intertwined in terms of attacking the problems for the most vulnerable. It's in a micro way, it's the same thing for spinal cord injury, where we don't just do clinical care, we also do the rehab care, we also do the reintegration of people back into their homes and checking out their homes wherever they are around the country to make sure they're handicap accessible. And we also do psychosocial services, which I think is a really key part of things as well. You know, Maxine on the right was under rubble for 16 hours in Port-au-Prince before they found him under his school. And Kenny had been bedridden before the earthquake, where he was just on his stomach for hours on end in Port-au-Prince, and they used the USNS Comfort, his family used the USNS Comfort to get him his first treatment, because there was no treatment even before the earthquake for spinal cord injury. So the hope that these guys bring to the rest of the group is really huge. So that peer sense of doing things and that integrated approach of looking at the whole picture has been really successful with this project. This is at our hospital. I point this picture out because it's our local team doing rounds, and you know, we're really proud of the local physicians that we have. Dr. Blaze on the right is our medical director, and what's great about this is a lot of the hospitals, although there are a few, they just don't even have this kind of ongoing medical education. So now there's a train the trainer going on here. A lot of these guys have been trained by docs from the outside, and now they're doing some training. They're passing on the education they had before during rounds, during education sessions. So there's a real sustainability to the education that's going on here. So the doctors and nurses, lab techs going on round through our men's ward and funding. This is our new lab, which has been sponsored by U.S. taxpayer money, the CDC. And you know, we show this picture too because you know, having these kind of facilities, you know, it makes a huge difference in terms of the care we can provide. And I think a lot of people will say, well, you know, the most cost-effective way to do things is to work through community health workers, and that's important. But I think with having these kind of facilities, they all play an integral role. And as you start to look at some of the global health things, you'll hear people talking about most cost-effective interventions. People may say this lab is too fancy and new and nice, but you know, now we're able to do TB testing that we weren't able to do before. We can detect that much more TB. By detecting that much more TB, we're making sure it doesn't spread and therefore become a real cost on the communities that we serve. So although there's a cost to this, really analyzing what the word cost-effective means is an important part, I think, of global health. This is mother and father and she's just delivered at the hospital. You know, I'm talking about the different programs and how good they're going, but our labor and delivery room is probably the size of, I don't know, from here over to the corner. So very small, maybe the size of like a mid-dorm. Maybe not freshman dorm, maybe a little bit up. But very small space. And there's 120 deliveries going on there every month with one OB. So we are happy that people are able to get emergency obstetric care, but it's really crucial to have the right adequate space for the work that we're doing. On the whole Southern Peninsula, so after all that aid, all those issues, the whole Southern Peninsula, which is about 2 million people, so from I'm jumping around here, and I don't have my Haiti map on the slides. If you ever looked at my hand, is a good representation of Haiti. Up here we have Port-au-Prince here, the bay is out here somewhere. The Southern Peninsula, it runs my whole thumb here. Fondé is about halfway down the Southern Peninsula when it goes back and looks at the map. So Fondé is about halfway down. From here, all the way from Port-au-Prince out, all the way to Jérémie here on the tip, 2 million people. We are the only source that we know of guaranteed emergency obstetric care. So if somebody needs an emergency C-section, they may be able to find it somewhere else out of that whole peninsula, but it's not always guaranteed that there's going to be a doctor there who can provide a C-section. And in terms of NICU, so neonatal care, babies that were just born, that we are the only source that we know of for the Southern Peninsula. We have 3 incubators. CDC tells us we have the only 3 incubators for 2 million. So we have preemies coming from 4-hour drive away over crazy roads to try and get in to one of the incubators. So here's one of our incubators, and this baby came from 4 hours away, survived. He was born at 29, or she was born at 29 weeks, and survived because of having the ability to get neonatal care. Now, there's different talks about this in terms of the global health. Neonatal deaths are a very high percentage of deaths under 5, but there aren't a lot of organizations that are working on reducing that neonatal death rate. So I think it's something, as people look at global health, would be an interesting area to explore more. This is the new maternity center that we're building. This is a picture from last week. So that I'm not the professional photographer of the other photos. This is my photo. But this is our new maternal and child health care center. And on the first, so I show this slide partially because it's exciting to see it going up, and it's amazing to see this finally happening after years of planning. But on the first floor is all training rooms for all the different projects. So for community development, for education, we didn't have training spaces that were appropriate. So the whole first floor is going to be training spaces and the sustainability piece. The Ministry of Health will be involved. The Ministry of Health will be bringing people, the Haitian Ministry of Health. So the public sector is involved, bringing out trainers, being trained, bring people from other hospitals to train on emergency obstetric practice, on neonatal care practice, best practices, neonatal care. On the second floor is a NICU, labor and delivery, outpatient clinic, so the service delivery. So there's the training and then the service delivery. And then hopefully as well some research happening too. And these are all local Haitians who are doing the work. We actually have one American involved in the construction process who's there on a daily basis. This is a new clinic going up in Vila, which was destroyed during the earthquake, and an outlying clinic. And here are some of the guys working on the maternal health center. And I think this is important too. As we talk about how all these things are integrated, some organizations are doing health, some are doing community development, some education, but it's all integrated. So they're all working on the maternal health center. After the earthquake, there are estimates that 250,000 people died. 250,000 people died in 55 seconds. Crazy numbers. The worst natural disaster or unnatural disaster in modern history. They all died not because of the strength of the earthquake. They all died because the construction wasn't done properly in Port-au-Prince. And in Chile, just a few weeks later, there was a stronger earthquake, or at least in the Richter scale, stronger earthquake, and I think they had something like 65 deaths. Their total sea change. And the whole reason for that number of deaths was poor construction. These guys are all laborers that are building all over Fundamental. Our area is maybe 7 miles, 8 miles from the fault line that had the earthquake. These guys were all using those previous construction techniques as they were doing different houses around town. They were doing different things. We have now, out of Boston, a former founder of a company called Charlotte Construction, who's on our board and works in Haiti on different construction projects. Jim is down there every month, and he brings people from Charlotte to teach these guys how to do construction in a better way, how to set up the rebar so that the rebar is attached correctly when the earth shakes, how to test the block to make sure that the cement block is correct. So it was a maternal health. It is a maternal health center, but there's all this other stuff going on the side too. There's the new construction techniques that are happening as well. So the more we can integrate all of that, the better. This is a picture of our graduating class from Philo, from the high school class in Fundamental. So this is first graduating class of the Philo is the senior year of high school, French equivalent. But really exciting to see these kids graduating. And then this is an example of a community development project. This is a chicken project for teenage mothers. So it is actually set up as a cooperative. There are teen mothers who are at risk for a number of reasons, as you can imagine, in rural Haiti, are extremely vulnerable in so many different ways, economically, socially, all different kinds of problems. And so we have an agronomist on staff. He's actually from Dorchester, Massachusetts. He's Haitian. We got him to come back home to fund it. And so he runs this project. It was his design. These are actually a special breed of real meaty chickens. And so the teenage moms are responsible for caring for them, and they're all part of a cooperative based on the amount of hours worked. And when they sell them back to the hospital for the feeding program at the hospital, they get some sort of income generation. And then this is a nutrition project with the CDC that we're running called the TFLA program, which is like small homes project. And this project is for severely malnourished kids. And we really like this project because it's based on positive deviance. Positive deviance meaning that within any group, any vulnerable group, some people have better practices than others around nutrition. And so there are some kids, even though they're extremely vulnerable, who are doing better than other kids who have a similar state of vulnerability. And so what we've done with this project is the kids who are thriving, our community health workers will identify them who are local. So the local population is identifying kids who are thriving despite the vulnerability. And then they actually teach the kids who are not thriving in a similarly vulnerable situation. They teach those mothers how they may be able to prepare meals differently so they're more nutritious and using local goods. So it's really a peer-to-peer teaching program that's going on. So, I think I've learned a lot over the last 10 years about what it means when you say, I want to help. I want to be part of things in international development. I want to be working in a place like Funded Law. I want to be working for the WHO. I don't know where you're working, but you want to be part of change for really poor areas like Funded Law. And I think, the first lesson I've learned is that all fields can help create change. Whatever you're passionate about, and some of these things may be cliche, but I think it's worth repeating. Whatever you're passionate about, whatever you really want to do, whether it's architecture, whether it's global health, whether you want to be a doc, whether you want to be in public health, whether you want to be a teacher, an educator, all these different fields that you may be passionate about all have implications in resource-poor settings like ours. I'm always amazed by the different fields that we have to bring together in order to make change in a place like Funded Law. And so whatever you're passionate about can be brought to the most vulnerable. The second one is development at work, in my opinion, should be judged on whether we have helped the most vulnerable. I think that is overlooked a lot as we look at some of these different projects. And so I think that's why you end up having a spinal cord injury program in Funded Law 3.5 hours outside of Port-au-Prince over really terrible roads. One doc called it a spinal cord injury waiting to happen, riding in the ambulance on the way out to the hospital. But the reason it's there is because there was a lack of understanding around what the most vulnerable projects were. And our staff, our Haitian staff, really understood that. I mean, prisons in Haiti. Prisons are the worst places you could possibly imagine, and not many people are working in them because they're overlooked and they're not, people aren't always looking at the most vulnerable populations. The third is that persistence, I think, is crucial. I learned pretty early on that although I had gotten to go to a great school like this one, it was still important for me to be part of the team that cleaned up the pharmacy depot and to get out the broom and work with those guys and learn about what their lives were like, work with the janitorial staff, understand where everyone was coming from, and to just stay at it for a long period of time. I think a lot of these places, Funded Law is no exception, they are very difficult places to work. When I was, it sounds like war stories, but when I was first there, we didn't have cell phones. And so, we didn't talk to my parents for like 9 months, which was okay by me, but maybe not so great by their standards. Having that kind of persistence around the work and staying there for the long haul, I think has really been important for a number of reasons. One is the local population is tired of people coming in, going all the time. that can get really tiresome for people because they come with new ideas and then leave, or they come with new promises and then leave. So being there over the long haul is important for building up trust, which I think is really crucial. I think the second part of it is that the work is really hard and there's a lot left to do. Sure, we have all these projects going, but man, we're just a drop in the bucket still in terms of the needs that are there. And so being there for the long haul is really crucial. And the lessons you learn. I mean, you learn so many lessons and so many different things just by being there that I think being somewhere for a long period of time is really important. And it's difficult. I'm now, for the last, since leaving about 9 months after the earthquake, I do about a week a month in Haiti, so I'm not even there the same way I was before. And there's always part of me that wants to be there more because being on the ground, being in a persistent situation is really important. The other is listen, learn, and adapt, and we've talked about that, but really listening to the local communities. But not just the community leaders, not just the men who come to you and say, okay, we want to do this project, because you have to be somewhat skeptical to why what everyone's reason for doing different projects are, but also going to people who aren't really speaking up in the meetings and hearing what they have to say, what they think is important. Because everybody has ideas about what's going to help them, and they know what's going to help them the best. And then the last piece, which is, in the development vernacular, cost effectiveness and sustainability have become real big catchwords. That this project isn't cost effective or that project isn't sustainable. And so what ends up happening is, in grant proposals, when you write grant proposals, they always will say in the grant proposal or the project proposal, tell us how this project is going to be sustainable after 3 years. Or tell us why this is the most cost effective intervention. Meaning, now that's pretty difficult. Sometimes we get people say, well, that's not cost effective. And you realize they're saying, that's not cost effective to save those lives, really. I mean, that's what's going between, when you read between the lines, I hate to sound melodramatic about it, but it's true. I mean, when they were saying that care and treatment for HIV wasn't cost effective, that was basically saying it wasn't cost effective to save a huge number of millions of people who had HIV. When we get bogged down in that, I think that we start to make false choices between what the really important things are. So really analyzing what does cost effective mean. I mean, if you're saving lives, I think by definition it's effective. The second is sustainability. We always put something in there in the sustainability piece. Hopefully this doesn't go on camera for too long. We always put something in there that says, oh, after 3 years this project is definitely going to ride on its own, it's going to be fine. We know that this project after 3 years, a National Center for Spinal Cord Injury after 3 years is going to be very difficult to just hand over to the government and say, okay, good luck with it. These are things that take a long period of time. They're not confined to a 3-year project a lot of the time. So really looking at whether you believe, as you look at the projects you're looking at, whether they really are sustainable or whether they are cost effective in terms of helping the most vulnerable. So those are some of the lessons that I have learned. I don't know if they're relevant to you. I hope they are. But I wanted to open it up now to question and answer period and hear some more thoughts from you. Some comments, some questions, and hopefully try to answer what I can. So thank you.
Conor, you mentioned that the Ministry of Health is involved in your new maternal and child health clinic and training center. Of course, ideally, Haiti would have a strong welfare state, and in the long run, that would really benefit everybody. But I was wondering if you could speak to your experience working with the Ministry of Health right now, and how that's been, and what your hopes for that are.
Yeah. So the Minister of Health right now in Haiti, specifically, is very qualified. She worked for a group called MSH in Cambridge, a big public health group, internationally known, has a lot of experience. She's very qualified. We have worked some with our department, our state too, our Ministry of Health Board, kind of like the Vermont Public Health Board, but for the South. So we've worked with them as well. I have found them to be very open to new ideas and new ways of doing things. But their ability to get involved is really dependent on us involving them. So in Haiti, I can't speak about some of the other places, but for us, that means like us giving rides to them to Fundebon to come to meetings, because they don't have any gas in the vehicles. It's it's thinking to that level of, hey, can we pick you up on our way out of Port-au-Prince for the meeting, and can we give you a ride back, 4 hours back? And people always come, they always come to the meetings. But I mean, we picked up the head of nutrition for the entire country, like on the way out to get groceries. Picked her up and brought her out for a meeting to talk about the nutrition program. So for us, it's really, we couldn't be more, we have to be extremely proactive in involving the Ministry of Health because their resources are so limited. But once we do that, they've been very helpful in terms of, showing us, there's always national guidelines that exist, but nobody knows about them. But they'll show us, like, say, national guidelines for the lab that we didn't even know existed by coming out to the lab, and they put together this great document on how to set up a lab in a place like Fontainebleau. It was totally irrelevant, but it really relied on us. Unfortunately, because the state is somewhat weak, it relied on us proactively seeking them out and getting them involved. That, yeah.
Hey, first and foremost, I just wanted to say I think your work is bomba guy, as I think the Haitians would say. And then I was really touched by the notion of cost effectiveness, because I guess something that's made me a bit skeptical of development and why I began to lean more into the business acumen is because in development you have a lot of cheap products essentially being given to people, and then in the business sector people are investing a lot of money to bring up the most expensive but the best quality treatment there is. And so I was just curious as to how have you dealt with that, especially when you're talking about the laboratory with all the fancy equipment, but that's allowing you guys to do a lot of testing. What would your words be to people looking into development? And
I think it's a good question, because again, I think there's a place for everybody at the table. There's some of these development groups that are developing what they call cost-effective interventions, like say a cost-effective incubator, or a new way of designing an incubator so that it costs less to produce, can be bought more easily by ministries of health and disseminated. I think those kind of interventions are fantastic. I mean, they'll allow us to have NICUs throughout Haiti in a way that we couldn't if we were just buying American-made incubators that were made in a similar way that they are now. So I think there's definitely a space for the business side of and the business development side of things to help. My sector is more around, and our mission is more around public health and reaching the most vulnerable. But we understand the importance of having the business development sector bringing up everyone as well with other interventions that are different from what I'm talking about here. So I hope that answers your question. I'm not sure.
No, not quite. I guess what I was really asking you is, there was a situation in Nicaragua where they built a really expensive clinic with marble wood and a lot of really expensive products in that clinic versus building 10 smaller, cost-effective clinics that didn't live up to the same standard of care compared to the one expensive clinic.
Yeah.
That's more the dichotomy I was asking.
Yeah, I mean, I guess I would love the one expensive clinic and the 10 clinics. I think sometimes what can happen is we get into this thinking that we have to do one and not the other, and sometimes that trap can lead us down a road that's dangerous. And I've seen it happen. Not to say that we should, look, at the end of the day, if the Ministry of Health has to make a decision, they have to make a decision. Are we going to do 10 or are we going to do 1? Because they have a certain amount of finite money. But when we're looking at an advocacy standpoint, and we're talking in general terms, I think we need to talk about the larger picture of what's really needed and how we're going to deliver that. And I don't think it's necessarily an either or, and sometimes we get stuck in false choices of what that really means. I think HIV/AIDS is a perfect example of, everyone was saying it's not effective to do treatment, it's only effective to do prevention, and that's a cost-effective way. And we only have a finite amount of money. Well, we didn't have a finite amount of money. President Bush, the Global Fund, all these groups realized, wait, we can find more money for care and treatment. And so through the advocacy of not accepting that false choice of prevention or treatment, we started to have the Global Fund, PEPFAR, people started to get care and treatment. They started to get antiretrovirals, and the disease became chronic for those who had it. And the weird thing that happened too, which I don't think everybody anticipated, maybe certain people did, not me, was that care and treatment became the prevention. So if you have AIDS, you're the only people who can pass on AIDS are people who have it. And so how do those people receive the education on how not to pass it on? Well, they've got to come to the health center, they've got to come to a health area, and if they're stigmatized because they're so sick they look like a skeleton, and they can't come to they're not going to come to the health center because they don't want to hear the news they have AIDS. Well, now there are drugs that are coming to the center, they're getting education. What also happened too is the treatment brought down the viral loads that they had in their bodies, and then they couldn't transmit it as easily. So this false choice of prevention versus treatment was that, a false choice, and became more important to look at what do we need to do here? What we need to do is save lives. And so how are we going to do that most effectively?
Thank you.
Yeah.
I really understand that persistence is crucial, but I think like a lifetime commitment is kind of difficult. What would be like determining factors for you to decide when you've like committed enough to like one project, and like when do you decide it's like time for you to move on?
It's a great question, and I don't think everyone has to do. Everyone has a role. I think everyone has a role to play, not the same role. And I think it would be dangerous if everybody played the same role. So I think to me, if people are finding what they're passionate about, that's the real key, and then figuring out how your passion can do the most good. Again, cliche, but I think it's really important that everyone will bring different things to the table. And we couldn't do the maternity center if we didn't have incredibly well-trained architects in Boston who built by Hall, doing the architectural work for the maternity center from Boston. If they didn't have that kind of training, if they didn't have that kind of expertise, we wouldn't have a maternal health center funded. So I think bringing those, whatever you're passionate about, and doing the most good is really important.
I have a question connected to that. I was just curious, you talked about the importance of being on the ground, and I agree, I think being immersed in the community to really be able to empathize and understand the real needs of the community is so important. So for college students who are on the Middlebury's campus for 4 years, is there something we should be doing these 4 years, or is it just kind of to be really focusing on finding what we're passionate about and being the best we can be in that field, so that when we enter the workforce and decide whether we want to get into international aid, that's kind of our entry point, or is there, what should we do these 4 years?
I don't know if there's any one answer to it. I think it's always complicated as to everyone's life path, but mine certainly had no idea I was going to get involved in Haiti when I was an undergrad in the way that I have now. But I think doing as much reading widely and learning from different sources. We've learned so much from different projects in different parts of the world that have had a huge impact on what we do in Haiti. And so there's a real opportunity here to do that kind of academic work and really beef up on the background that you have before you start projects and work. And there's great literature out there. There's way more now than there was back then even on this kind of work. And then I think the other piece is, I think you're right. I mean, I think focusing on where you can really build up a skill set that will be helpful is really important. Because it's one thing to go and volunteer after undergrad, it's another thing to build up a skill set over a career and then being able to go to a place like funded. So I think you're right. I think you're onto something. Yeah.
How did you choose this organization? Like, how did you choose Haiti? I know it seems kind of like serendipitous that you started the English teaching and then moved on to more of the public health roles, but just like before the decision to even go, what kind of led you to this?
So I went down with St. Boniface for the first time when I was 19. I was in a J-term course, issues in sports. I don't think that class exists. D. Rowe used to teach it, and he said that I could miss half the class to go to Haiti, as long as I talked about sports in Haiti when I came back from the trip. But I went to Haiti during J-term for a week or for 10 days with a local parish group just outside of Boston. Local parish I was with. My mother is Catholic, my father's Jewish. So I went with my Jewish father and our Catholic parish group down to Haiti and just fell in love with the place. The second piece was that my junior year, I was in another J-term course with Governor Tunin that was private actions for the public good. And one of the speakers was Paul Farmer, who's now on the St. Boniface board, and he's been an incredible mentor for the time that I've been working in Haiti. And so when Paul came up, I was joking, there were like 12 people here to see him speak. And Paul came in like January on Super Bowl Sunday, so nobody came because the Super Bowl was going on, and no one knew who he was because the Mountains by Mountains hadn't come out. And he showed up in just a suit, no jacket, nothing. So the way I got to know him was that we found him a jacket in January for a month. But you know, that's how I got involved, was those first trips. And then, you know, Paul knew St. Boniface and encouraged me to go back. But it just grew organically.
Do you think that maybe the balance between NGOs and corporate business investments is too wide in developing countries?
It's a good question. I mean, certainly in Haiti it is, because the inequality in Haiti is huge, and so there's definitely a big gap between the realities of the Haitian poor masses and business leaders in Haiti. It just exists. You know, I don't have the answers of how to make that better, but I think, you know, for those of you who are interested in going into business or going into the private sector, you know, I think keeping in mind how to use the actions of that business or the private sector for the public good, especially the most vulnerable, is really important. And some businesses have been able to do that well. You know, there's clear examples like Tom Shoes, or one of the groups where they're giving the shoes out after you buy the shoes, which is an interesting example, but there's other ones too of, say groups that are doing HIV/AIDS care and treatment for their employees in sub-Saharan African companies. Thinking about those kind of things as private businesses, I think, are really crucial. And you know, frankly, probably a good business. Any other questions? So just one announcement is, if you go to our website at HaitiHealth.org, which I particularly did not put on the PowerPoint, HaitiHealth.org has more information about organization. We have 2 job openings right now. One is a volunteer opportunity to run our residence in Haiti with a volunteer stipend. But it's a 2-part job. It's running the residence as well as doing communications work. So taking photos of what's going on the ground, putting it on our website, articles, doing interviews with our local staff, getting the word out about what's going on. So that's the residence coordinator volunteer post. And then we also have a development coordinator post, which you should be able to. The residence coordinator post will be posted in the next 4 or 5 days, and the development coordinator post is already up, and we're accepting applicants. So if anybody's interested in working in Boston too, we have the development coordinator post that's open.
And Conor, if you send us those, we'll put them on the newsletter, so those that aren't here
Yes.
can see it.
Yes, I will.
So there's a delightful connection with D. Rowe. A protege of his had the idea of bringing the Center for Social Entrepreneurship here. And the sports development connection really was very foundational for us. And so when we kicked off the center, he was here, and it was very meaningful.
Great.
He remains really quite a presence. Yeah, thanks for sharing that story. That was
Yeah,
great.
no, he was great.
Yeah.
Well, I think that's all we have time for, but a lot to think about, a lot to process. But thank you everyone for coming, and let's thank Conor one more time.